Hello, in this episode, you get to meet one of my patients, Mr. Williamson, and his wife. This is a wonderful couple. They do a great job of describing vestibular rehab for patients who undergo vestibular schwannoma surgery. It's important to know that even though classically we used to call these acoustic neuromas, they're not acoustic neuromas. They don't come from the cochlear nerve or the hearing nerve. They come from the balance nerve. And so balance therapy or vestibular therapy both before and after surgery can be extremely important. So in this episode, I'm going to do a little bit of teaching. I'll describe to you the different approaches, surgical approaches, whether it be retrosigmoid surgery, translabyrinthine surgery, or middle fossa surgery. And I'll also describe some of the balance aspects of this surgery. Mr. Williamson and his wife, how did you even find this tumor?
Yeah, I started getting some dizzy spells, and when it got worse and it was vertigo, I got an MRI done, and that's when they discovered the schwannoma.
And what was the scariest part of this whole process?
The scariest part at that time was that the tumor was too small to operate on. The risk-benefit just didn't really make sense. So it was wait 6 months and get another MRI. And to not be able to do anything for 6 months was really hard for me, to just sit and do nothing.
The big scary once we got moving again was the word craniotomy.
Yeah.
Because, it's always the procedure and kind of general simple terms, and it's not such a scary diagnosis, it's just a kind of scary treatment. But craniotomy, said by a neurosurgeon, is a daily word. For us, it was first time we really thought about that, and hearing Dr. Lee speak so confidently and calmly, and I do this every Wednesday and sometimes on Fridays, just really gave us peace about we were in the right place with the right people.
Right.
Dr. Reckenstein and Dr. Lee seemed to be a great team, worked well for us.
So Mrs. Williamson just said something interesting. Craniotomy can be a very scary word. For patients who need craniotomy for their acoustic neuroma or their vestibular schwannoma, I'd like to demystify that right now. I want to go through 3 examples of how we do this. What I'll show to you right now is a diagram of an acoustic neuroma. So imagine this is a cross-section of somebody's head. Your eyeballs are up here. And the cerebellum and the middle cerebellar peduncle and the pons. So the pons is over here, which is part of the midbrain. You have your 4th ventricle and the cerebellum here and cerebellum here. Now, the brainstem is very important. We have the petrous temporal bone. So this is bone. And actually, just curious thing, why is it called petrous? This is an aside. I believe this comes from Peter, and Peter was the most faithful disciple of Christ. And so when you unearth skeletons in archaeology, the most solid part of the bone that remains even after you crack the skull or after eons is the petrous temporal bone, because it's so much bone and so solid. Well, in any case, that's the petrous temporal bone. Now, your ear would be here, and coming out of here is the internal acoustic canal. You have your cochlea here, which is the organ of hearing. The tumor usually starts in this internal acoustic canal and then grows this way. So let's draw that again. Again, we have our brain here, and then we have the pons, which is here, brainstem, and the cerebellum, 4th ventricle, and the petrous temporal bone. The internal acoustic canal is here. I classically call these tumors ice cream cones with a scoop. So the tumor can be intracanalicular, so it will start just here in the internal acoustic canal. It can then pooch out into this space that we call the cerebello-pontine angle. and into the cistern. So if we get into that cistern, the tumor is just a little bit larger. And then if it starts denting on the pons or the brainstem, that's obviously much larger. And then of course you can get these much larger tumors. But there's a small portion in the internal acoustic canal. That's the ice cream cone, and then how big your scoop is how large the tumor is. So that's how I think of these acoustic neuromas. So approach to these tumors. So now for your approach to the tumor, again, we have the brain, the pons and cerebellum. So here's the pons, fourth ventricle, cerebellum. If the tumor is in the IAC and it has this scoop part, there are different ways to approach it. If I'm trying to save hearing, in general, I'm going to come retrosigmoid. Now, sigmoid is referring to a sigmoid sinus, which is a venous structure. And I'm going to come make a craniotomy from here to here. I'll replace this bone at the end. And I'll find this natural cleavage plane in through here to attack the tumor. Retrosigmoid. Now, I do have to gently retract on the cerebellum here to get to the tumor. And then this bone right here, we will drill away in order to get to the internal acoustic canal in order to get a gross total resection. So I generally divide this into two parts. I take out all of the tumor in the CP angle here, and then my ENT colleague will drill away this bone and tackle this portion of the tumor. Now, in other countries, neurosurgeons can do all of this, but here in the United States, we like to work together with our colleagues. So the other approach would be in front of the sigmoid. In a way, you can call it a pre-sigmoid. And any pre-sigmoid approach can be divided into a retrolab or a translab. And so in this case, the labyrinth refers to the semicircular canals which are here. We keep the cochlea intact, even though you end up not being able to hear if you come through this way, but the approach is this way, and this is a translabyrinthine procedure. You automatically lose hearing, but you can see how the trajectory is straight. And that's one of the advantages of doing the translab. So there's the retrosigmoid, which is a little bit more oblique approach, depending on the configuration of the tumor, versus a translab. So for surgical approaches, there's three classic approaches to this. Retrosigmoid, and you just watched me describe that. Translabyrinthine. And then the third approach is a different trajectory, and it's the middle fossa. And that's also a good approach, but the downside of it is you can only tackle small tumors, whereas this is very versatile. The retrosigmoid, you can tackle everything, and you can save hearing. The translab is very nice because it's straight. It's a very straight approach to tackle the tumor, but you lose hearing. So that's the downside of it. So these are my three surgical approaches for acoustic neuromas. And I love tackling these tumors and have developed a lot of skill in doing that. But of course, we review this with you and come up with the best approach for you. And now you're how many weeks out from surgery, from your craniotomy?
4 weeks.
And how do you feel?
I feel great.
Turn your head.
I can turn my head without falling over. The balance was tricky coming out of it. But I think one of the things that helped the most was we found somebody with experience in vestibular physical therapy and gave me exercises to do that have helped so much.
Okay, for purposes of vestibular therapy for acoustic neuromas, you have to recognize there are three components to your balance system. One is your vestibular nerve, which the tumor comes from, and then the vestibular labyrinth. And that we'll talk about that. Number two is your vision or your ocular system, your eyes. That's very important. And number three is your proprioception, which is how you feel the world or your joint position and your kinesthetics and kinematics. So on one side where your tumor is, this is going to be knocked out. So you need to rely on this and this. You need to train this. And my patient goes through a great example, a description of how he does that. So what is the vestibular system? So imagine your ear, and you have your external ear canal where the wax builds up, the eardrum, your three bones that conduct and then go to the cochlea. But the cochlea is also attached to the semicircular canals, which sense where your head is in space. If you move forward, turn, rotate, etc., acceleration, deceleration. Then from there comes a nerve, and that nerve is where the tumor arises. Now, this nerve then goes to your pons. So the pons and the brainstem, where we're operating. So we talked about this. Here's the cerebellum, and here's the cerebrum up here, your brain, where the higher order functions are done. Now, the balance system, this is the number one system, but then that connects to your eyes. And your eyes over here are very important. So when you practice balance, you do vestibular therapy, you can close your eyes, open your eyes, and practice. And so if you feel unsteady, fixate your eyes on something to help with your balance. And these are things that you have to train. So, and then the third system, which is your proprioceptive system, is where the balance system then connects down the spinal cord to the muscles and tendons in your body. So here you can practice standing on one leg, moving, just getting an understanding of where you are in physical space. And my patient describes this beautifully, and I think is an incredibly important part of therapy. What exercises seem to be the best?
Well, it's a combination of different exercises. So your balance is informed by your vestibular system, your vision, and just your body's self-awareness is what I call it. So if you close your eyes, that eliminates vision. And at first I would fall over just, closing my eyes. But then different exercises to challenge your body's self-awareness, or turning your head challenges your vision. And all of those things together just help the vestibular system make sense of what's going on.
So always standing in a corner, so if any falling happens, you fall right into the wall.
Right.
And at the beginning, simple, can you put your feet together? And then can you put your feet together with your eyes closed? And then can you put your feet together, eyes closed, and turn your head? And then just gradually increasing speed, increasing difficulty, spreading getting your feet in line eventually.
Yeah, so last week we were in a gym, like basketball type gym, and walking fairly quickly parallel, throwing a tennis ball back and forth. And
3 weeks after surgery.
yeah.
Beautiful.
Yeah.
All right, well, very good. I think that's great.